we talked about the Duane syndrome, and the Duane syndrome has been classified into 3 different types. And in the first type, we have a problem with abduction, so it can look like a sixth nerve palsy. The tip-off usually is in primary position. They look relatively straight because it's an innervational problem. The sixth nerve, which normally innervates the lateral rectus, is not present, and so they cannot abduct. But in primary position, they're relatively straight because the medial rectus is not unopposed. It's just not being asked to fire because the lateral rectus is missing. And in the type 2, that is the adduction problem. So they cannot adduct, and you notice the 2 Ds in Duane 2 and only 1 D in type 1. And in the type 3, we have both an abduction and an adduction deficit. There's also a different type, which is sometimes called a 4th type, which is caused by attempted adduction actually leads to paradoxical abduction. So instead of the eye adducting, it abducts. And that's because the innervation is split between the 3rd and the 6th, but the predominant innervation is the lateral rectus, and so the eye abducts. Sometimes that's referred to as synergistic divergence, but this is a paradoxical abduction in attempted adduction. The reason you need to know about the Duane syndrome is it's congenital. You're born with it. You're missing the 6th nerve nucleus, or there's a split in the innervation between the 3rd and the 6th. But it can mimic a 6th nerve palsy or an INO, and is on the differential of an esotropia or an exotropia or an ophthalmoplegia. And so the patients who have the Duanes, we really have to look for the distinctive finding, which is on attempted abduction, the lid fissure will change. So there's narrowing and widening of the fissure when they move from abduction into adduction. There might be a downshoot as well in adduction. So the lid fissure widening and narrowing during the attempted adduction is a clue that the patient actually has a congenital miswiring, the Duane syndrome. So you need to know about the Duane syndrome. It's congenital. There's type 1, type 2, type 3. 1 is the abduction, 2 is the adduction, 3 is both. There's this paradoxical abduction phenomenon from attempted adduction because the split in the innervation is mostly to the lateral rectus. The Duane syndrome can mimic 6th nerve palsy or mimic an adduction deficit like an INO. The lid fissure narrows and widens with abduction and adduction and is a distinctive feature, and there may be a downshoot in attempted adduction or abduction depending on type 1 or 2. Because of the abnormal innervation, the muscle slips and the downshoots and upshoots. Usually they're asymptomatic. They often are straight in primary position, and you should know it and keep it in the differential diagnosis of esotropia and exotropia.